right, I think we'll get started. I'd first like to start this session, and I think it's really important that we start this session by recognizing and acknowledging the land that we're on. And this land is the unceded territory of the Coast Salish people. So we are guests here on the land of the Squamish, Tsleil-Waututh, and Musqueam people, and it's my honor to be here. My name is Dana Hubler. I am a family doctor in Vancouver Island. I work with the UBC Rural CPD program and with the Island Health PQI program. And I am the moderator for this session today, which I'm really excited about because we have some people who are real leaders in this work, and I think there's lots to learn. This is a rapid fire session, so these people take all of this amazing work that they do and condense it into 10 minutes for us. And then we have 8 minutes to ask questions and try to tease out all the things that we want to get out of the session. So that's the challenge we have for these folks, and we'll try to honor that time. The topic today, as you well know, is social determinants of health, zooming out to see the big picture. And the 3 sessions that we'll have today, the first one will start with the Kootenay Boundary Division of Family Practice, talking about screening for social determinants of health in the Kootenay Boundary area. That will be followed by Northern Health's work with the Equip Healthcare, implementing health equity interventions at the point of care. And then we have a guest from Saskatchewan, and she'll be talking about supporting health system improvement through expanding our focus. Just a few housekeeping items. On your seats are evaluation forms. If you could please fill those out, that would be extremely helpful to us. And when we get to the Q&A session, I know some of us feel shy about using the microphone, but if you could please bring yourself to use it, it will be really helpful because we have live streaming guests that are part of it, so it'll make it more interactive for those folks that are joining us from their homes or offices or other places. So I think with that, we'll get started with Joel Kailia and Leila Dale, who are with the Kootenay Boundary Division of Family Practice.
Good afternoon. All right, so we're going to present a project that we've been working on with the Shared Care Committee in the Kootenay Boundary region. My name is Joel Kailia. I'm a GP doing chronic pain and addictions.
And I'm Leila Dale. I do quality improvement for the Kootenay Boundary Division of Family Practice, and I'm the project evaluator for our project. And we have no conflicts of interest to report.
Okay, so this project has to do with the Adverse Childhood Events Questionnaire. Does anyone have never heard of the ACEs before? Okay, good. So we don't have to spend a lot of time on this. So we all know that this is a very important thing to be screening people for, and I got involved in this project because I had read about how much of an impact it has on my patients' health in terms of the chronic illness, and I had a lot of patients doing chronic pain and addictions who were not getting better, and I was finding that screening for adverse childhood events opened up a whole conversation that then allowed us to kind of get at the deeper problem and allowed us to kind of get moving and go forward. So that's why I got involved in this project. So if you've read any of the literature or been keeping up to date, we know that an ACE score of 4 or more predicts negative health consequences in a large range of chronic illnesses, and is a huge burden on society and the medical system, and that's very important.
And we also chose to focus on poverty for our project. It exists in Kootenay Boundary. 6 out of 7 of our local health areas have a lower average income than the rest of BC. Okay.
Okay, so my part in this was to try out the screening process. So basically, how do we get family doctors and specialists to screen for ACEs? And then how do we communicate with each other about that ACE score? How do we maintain confidentiality? How do we code this in our system so that we can find it? And then how can we encourage the ministry then and the Doctors of BC to have a complex billing code for doing this kind of work?
Right. But we found that there was a lot of hesitancy still among providers in our region to do this type of screening. So this just shows our project improvement goals. So we wanted to embed in-practice screening for poverty and ACEs into clinics, increase poverty and trauma-informed care practices, systemize the integration of poverty data and ACE scores into EMR, and share this information from GP to specialist referrals. Our project activities really has centered around developing some tools and then implementing them into primary care clinics in our region. So we started with the poverty intervention tool. This has been around for a few years, and we worked on just really implementing this into clinics. It's asked a basic question of, do you ever have difficulty making ends meet at the end of the month? And then from the answer there's further questions that you can go through. And then we developed and implemented our Asus Toolkit. So this asks or provides information about why ask these questions, who to ask, and how to introduce this with patients, how it can work, how you can administer it in your workflow, and then how to discuss the results. With the simple validation of, I'm sorry this happened to you, this should never have happened, how might this be affecting your health today? And then also how to code this at EMR, which we'll talk about a little bit later. Our EMR integration activities included having a PDF version of the ACE questionnaire in Profile and MedAccess EMRs, which are our top 2 in the region. So that could be just printed right out of the EMR. And then also developing an ACE profile item and observation template for both of these EMRs. So this includes a drill down for each ACE questionnaire that, when expanded, includes a numeric observation field, so you could write down the score. So who have we reached? Well, I'm really pleased to say that 115 practitioners in our region have heard us talk at least once about this project. So we've definitely planted the seed, and 76 of these were family physicians, representing half of the GPs in our region. So we've spoken to them at our local Kootenay conference. We've done hospital rounds presentations on ACEs at our 3 main hospitals. We've put on a few trauma-informed care workshops with our maternity and pediatric teams at 2 of our main hospitals. And then we've done the in-clinic training, where we've taken these tools into clinics, and we've so far had 42 providers in 9 clinics take part in this. 23 of these were GPs, 2 specialists, 1 resident, and some nurses, social workers, and even a community paramedic. So have we made an impact? Well, we collected some data from the hospital rounds presentations. We did a pre-presentation survey and then followed up with a post-survey. And we were interested to see if there was a change in the understanding of how ACE tools in the field. And as of press time, I guess, for these slides, we'd only had 20 providers who had passed that 6-month follow-up mark. And 14 of them did our survey. So about 60% follow-up rate there. And the changes in scores from pre-training to 6 months post wasn't as pronounced as the rounds data. So, and in fact, confidence to discuss ACEs didn't change. It remained steady at 6.5 on a scale of 1 to 10. But the baseline confidence scores were higher for this group, and so they didn't change as much. So people might have been feeling pretty confident coming into our training, and then after a few months of doing this, realized, yep, this is actually pretty challenging. But I'll note that, again, this is only from 14 people. We've trained now 42, and we have more training planned, so by the end of the year, we should have more of a robust sample there. So looking at this group of 14, we have 13 out of the 14 providers reporting that they're doing the poverty history taking, versus 11 out of the 14 who asked this at least once at baseline. And 11 of 14 reported doing ACEs history taking, compared to only 6 of 14 at baseline. And over half of our providers were asking more patients about this. So we're seeing more providers asking, and they're asking more people, which is positive. And of 10 who asked their patients, 100% said that it improved the relationship with their patient, and 8 out of 10 said it influenced their treatment plan. So 2 were unsure whether it did or not. Oh, sorry. Don't have time for that one. So we found that there's definitely an appetite for knowledge on trauma-informed care and social determinants of health in Kootenay Boundary. We've spoken to a lot of providers. Our project team also had lots of conversations with other agencies. Our toolkits are up on Pathways. They're also on our division website for anyone wanting to take a look. And we've had at least one other division of family practice ask if they could tailor our toolkit for their region, which we were really excited about. So speaking to physicians and other providers about how to do this, we've seen an increase in understanding, increase in confidence for some people, and increase the number of patients who've been asked. And that's just a quote there from one of our providers of how it's been useful for them. But we do have ongoing challenges. So our follow-up group of physicians reported that they still have some main barriers. The top 2 were forgetting to do the screening and a lack of resources or support to offer the patient. And now our little piece on coding. I would love to have some discussion about this later. We've chosen to use these 2 codes. There's a little bit of mixed feelings about whether this is the right approach. Joel's just going to quickly talk about why we chose to do the coding.
Yeah, time's up, but ICD-9 doesn't have specific codes for these diagnoses, so we just chose the closest ones. They're a little general, but we're hoping that MSP will update to ICD-10, and in that case there will be more specific codes. And then the reason for coding would be for collecting of data, and if there ends up being a billing code for complex care for treating these type of patients, we would need a billing code for that and a diagnostic code. So it's still in the works.
And just according to our providers, what would make it easier for them to do this is having a billing code, more convincing evidence of better outcomes with provider-patient relationships, visual reminders to do it, and then integrating this into our primary care network. So that is what is our next step. Kootenay Boundary is a phase 1 community for primary care network, and we plan to go into these clinics and talk to the teams, including the social workers and nurses and physicians, about how to incorporate social determinants of health into team-based care and workflow. And also we'd like to talk to our specialists about if they see a referral with this kind of information, what exactly that means. Whew, and that's where we're at with this project, so we'll still have more results to come. Thank you.
I just came in late. You said your toolkits are on Pathways. Which Pathways? There's lots of Pathways out there.
Do you know what?
I would assume Kootenay Boundary Pathways.
Yeah, so I've just heard it's on Pathways.
Is that a part of
actually know what it
Division
is.
of Family Practice?
Yeah,
Okay.
Family Practice Pathways, yes.
And it's also on the Kootenay Boundary Division of Family Practice website.
Okay.
There's links there too, right on off the homepage. Actually, and if for those tech-savvy people, I forgot we have the QR codes that you could scan to access it right now, if it works.
Hi, thank you for the presentation, and I think the work that you're doing is really, really important. I was just wondering if you guys have any data or are going to collect any data on kind of the patient experience and whether or not, I guess, screening for ACEs is helpful to them, and what some of the supports are moving forward once, physicians have screened and have the data available to them.
So, do you mean supports for the patient? Yeah. So we do plan to do patient interviews. We've gone through an ARECI ethics screening to kind of prepare for that. ARECI is an Alberta-based ethics tool. We just haven't got to it yet, but that is our plan. As for the supports, our project really is focused around that just in and of itself, asking patients about ACEs can be healing. We're trying to encourage that you're not there to fix the problem, but just to validate what's happened to someone. We do have social services in Kootenay Boundary, and it's a matter of just, I guess, making sure people know what's out there, including the physicians of where to send people to, and that's something that has come up again as a bit of a challenge.
My personal experience has been that patients have, because of disclosure in the ACEs, have been able to steer them towards things like the Victim Assistance Program, which can then have trauma counseling covered.
Can I go ahead?
Yep.
Okay. Hi, I just wanted to introduce myself as a public health physician. So I definitely have a bias towards addressing social determinants of health. And my question was around, the toolkit, and particularly I think there's been work in the UK of having sort of patient navigators attached to practices that can do that social service referral that I think is extremely fragmented here in BC. So I can understand family physicians not having the time to, follow through with a toolkit, and then the patients themselves not having the resources, even if they're given the information to be able to follow through with that. So I guess my question is, do you feel like that would be something useful to help with that second step around actually implementing the toolkit for clients? And I guess I can see, just imagining the resistance of someone, a physician not wanting to ask because they feel like they don't actually, if the person needs money to pay the rent, they are not in the position to change that.
Yeah, it's absolutely a concern. So we do think with our primary care networks that having the social workers on board with this can help patients find the right services if they need them. Do you have anything?
No, I agree. I mean, that's one of the physicians' concerns, that they're going to open up a can of worms, and that is possible, but patients do want their physicians to ask about this, and so I don't think we should delay for that, but I think the physicians who had the primary care network in their office and they had access to a social worker and they were able to kind of refer right there in the office to a social worker, I think had the best experience with this.
Thanks. I was going to say, it is heartening to hear that just asking the question is an effective intervention or is helpful. But I would have guessed that if you had a lack of uptake with the primary care providers, that it would have been because they perceived a lack of supports once they started the conversation. I mean, even if I know it's effective to just ask, I would have a hard time knowing that I had nothing to offer, or limited.
Limited, yeah, but you have your assurance that you're on their team, and the acknowledgement that these things happen, that they were wrong. That can make patients feel quite a lot better, and can also steer them away from always demanding certain things like imaging and specialist referrals, and you can actually kind of start to get at the underlying problem. So kind of shift the focus of where, if you're stuck with patients.
Nurse practitioners often have a focus and expertise in social determinants of health, and I'm just wondering if they were included in this. I just didn't see that.
Nurse practitioners, we've had one. I don't think we have too many nurse practitioners in Kootenay Boundary. We've definitely had two. We've had two come to our training. Yeah.
Can you go back a couple of slides? I'll tell you. There was some comments there.
This one?
This one. I guess the theme I'm hearing between the lines, and I'm going to be explicit, is I'm always concerned to open a can of worms if you have nothing to offer. So if you don't have the social worker in your office, if you don't have a long-standing relationship with the patient, I think you can possibly re-traumatize somebody by asking about domestic abuse or anything, childhood experiences or anything like that. And I thought that comment on the right-hand side is one of the unintended consequences of documenting adverse childhood experience, what can happen. So that would be my fear, is that without having a good long-standing relationship with patients and having more than 10 minutes for a patient encounter, and not having the social worker in the office or in the team base, we may actually do more harm.
I hear you, and that is definitely a concern that we addressed. I would tend to disagree at this point that we should still ask the questions, because it is therapeutic for the patients to have that relationship with their physicians. And we're not actually we're not encouraging people to document the actual abuses or things that happen to them. We're just documenting the score. So it's kind of, we retain some confidentiality that way.
Is there one last question? No? Okay.
Thank you very much. So we'll welcome Erin up from Northern Health.
Just get the mic just right. So, good afternoon, everyone. Thank you so much. I'm really happy to be here on behalf of this fabulous research team to talk to you a little bit today about a study called Equip Emergency, and just to acknowledge our funder that this study is funded by CIHR. Where do I have to point this? Maybe I'm going the wrong way. Maybe I'm holding it wrong. Oh, there we go. Okay. Okay, so I don't really have any particular disclosures except to say that I do work for Northern Health as a family nurse practitioner, and but that didn't inform any of the content that was developed today. So, I'm going to keep up with my notes. So the objectives today are really just to give you a little bit of an orientation to the Equip program of research, and then to focus in specifically on what we've been doing with Equip Emergency, and to highlight some examples of strategies and approaches that we're using to discuss some implications for health equity interventions. So EQUIP stands for Research to Equip Healthcare for Equity, and the way in which we conceptualize equity-oriented healthcare is really foundational to the EQUIP research program. And it means paying particular attention to those who are at greatest risk of poor health, and that typically means people who are most affected by the negative impacts of social conditions such as poverty or lack of affordable housing or racism or other types of discrimination. If you were in the talk this morning, you're going to recognize a few of these slides just because we really want to emphasize the key dimensions that underpin this approach, and that EQUIP's take on equity-oriented healthcare really incorporates these three key dimensions. I'm just going to define them for you, because I know there are terms that we talk a lot about, but just so that we can all be on the same page and thinking about what we mean when we talk about, for example, trauma and violence-informed care, and that means understanding and working to limit the effects of trauma and violence on people's lives, health, and healthcare experiences. That culturally safe care means trying to reduce power imbalances, racism, and discrimination that can often play out during health encounters. And also harm reduction, which is an approach to service delivery that focuses on preventing the harms of substance use, including stigma. So with these three key dimensions, they all overlap, and they can all be tailored to context, which means you might have more of one in a certain place and less of the other, and that the strategies that flow out from these key dimensions are meant to guide healthcare workers and organizations to improve abilities to provide equity-oriented healthcare. So this slide, I always feel like I need to step out to explain a little bit. The mic's not going to come with me here, so I'll just gesticulate. These are the findings that are kind of summarized from the EQUIP primary healthcare program, and I'll show you how from there we've led into the EQUIP emergency program. And so the staff impacts are really around how staff can provide equity-oriented healthcare, and what happens is that over time we can actually predict how it can improve health outcomes for patients, because as staff are able to provide equity-oriented health care, patients actually feel more confident in receiving care, and that turns into their confidence being increased in terms of being able to manage their own health conditions. And then over time, this actually lowers their depression and trauma symptom scores and improves their quality of life. So this is, has formed a really nice evidence base to show that providing equity-oriented healthcare with the underpinnings of those 3 key dimensions helps patients. So EQUIP Emergency is the study that has followed the EQUIP primary health care. So this is where we're adapting it and tailoring it to a different but obviously related context. So this project is a tripartite partnership model, and so we have researchers, leaders from Indigenous and non-Indigenous communities, and staff and leadership from 3 different emergency departments in British Columbia who are participating in this study. The emergency department seemed like a really natural outgrowth from after looking at how to provide equity-oriented health care in primary care settings, and partly because you know, when we talk about mismatches, like what's inequity about, it's often about the mismatch between what people require to achieve wellness or a better state of health and how services are provided, that sometimes these mismatches are happening in emergency departments. They're a place where the, you know, one of the last remaining places where the doors are always open, and but the structure of how the services are provided sometimes leave both patients and providers feeling unable to receive or provide the care that they were hoping to have. So the overarching goal of EQUIP Emergency is to be able to create a framework for equity, to promote equity-oriented care that can work in different emergency departments across Canada. And so you can see the objectives there, and then some of the analyses are planned around examining these impacts. So I'm going to just kind of try and explain a little bit of how the study is unfolding. So we're collecting quite a range of data, and I have a table at the end to kind of show you some of the data sources, but we're doing things like waves of patient surveys, and these surveys are a little bit different than your typical patient experience survey because we do ask about experiences both of everyday discrimination, so you know, if they feel discrimination, experience discrimination in their everyday life, as well as experiencing discrimination in healthcare settings. We've done staff surveys, and then the kind of core piece of this is that it's informed by the principles of frontline ownership, which means we've invited diverse staff groups, so anyone who works in emergency. So that can be nurses, social workers, physicians. It also includes housekeepers, security, rest therapists. So if you work in Emerge, you're eligible to join the working group. And the idea is that we had a 6-month catalyst period to take the working group at the 3 sites through a change process where I'm going to show you some of the data sources that they had access to and how we led them through this so that they could identify their own strategies and interventions that they thought they would like to take action on in order to promote equity-oriented healthcare. So this is just a little bit about the working group. So as I said, it does engage with diverse staff. We give an orientation overall to the project, which I'll break down for you in a few of the different steps on the next slide. And then they use some of the information to sort of assess the department in order to be able to develop some of these strategies. So the working groups are all provided with an orientation to equity-oriented healthcare, and this includes access to the freely available EQUIP online modules. So I'll show you the website at the end if you're interested. These modules are available. I also have postcards if people are interested to take away with them, so please just come up and grab one if you'd like. We created context profiles for each of the 3 sites, and that's because, you know, sometimes people are commuting into the places where they're providing care. They don't live in that community. Other times it might be that they didn't grow up in that community. They might not be aware of all the historical context that contributes to the way that health services are structured or delivered in that particular area. So we also gave data snapshots from the patient and staff surveys that I was just mentioning, so kind of highlighting or, you know, presenting some of the significant crosstabs for them to consider, and then allowing them to have access to 2 different types of coaching if they requested it. So both a change coach, which can help groups, especially from diverse disciplinary backgrounds, to get unstuck or have some of those challenging conversations, and then also a content coach. So if they wanted to initiate a particular strategy or intervention, that someone would be available to guide them or help ensure that all the theoretical principles could be done in a way that was going to work for the department And then the workbook is kind of the last thing. So we created I like the workbook, and it's the working groups could use it to do a lot of the activities to try and assess their department and to kind of keep track of how they were assessing the strengths and weaknesses, opportunities and threats. So over this 6-month period, they did have access to a Catalyst grant of $10,000 to support the work that they selected. So this is just a little visual of how some of those data sources came in to inform how the working group could assess the department. And so to date, we have surveyed over 2,000 patients at the 3 different sites. We've just finished 3 waves of patient data collection at each of the 3 sites. 2 waves of staff surveys have been completed, and now the Catalyst period of intervention at all 3 sites has closed. So I don't have any findings to share with you today. I just want to talk with you about some of the things that we're doing, and so this is kind of where we're at with the study. And the last slide I'll show you is a busy slide, but this is just to kind of highlight for you some of the research questions we're hoping to answer here on the left. And then you can see that we have this variety of data sources, so patient, staff, admin data, as well as a lot of interviews and observations and field note data that we've collected from being in the department and working with the working groups, and then conducted through a variety of analyses. So with that overview, I wanted to kind of direct the discussion because, of course, that's the best part of the session. And so I wanted to ask this question because, of course, many of you in the room I know are going to be really familiar with the competing pressures and priorities in emergency departments, whether it's capacity or flow or staff shortages. And this can contribute to a really hectic environment. So I wanted to ask, what do you think it might take to promote equity-oriented healthcare at an organizational level? So I'll stop there, and I'd be very happy to hear from you. Thank you. I don't have the mic, but I see you have a question.
I think that what you're doing, and this would inspire me to participate, is going to increase both patient and provider well-being and both of their outcomes. And so I think that's pretty compelling.
Yeah, absolutely. We talk a lot about the quadruple aim, and I think that that's really obvious from the primary healthcare study that actually when you can improve staff confidence, like it makes your job easier, it's less distressing, and then to know that it's helping patients, really, I think it gets at a lot of those issues. Thank you.
I think of, let's say, emergency departments. If there was a health authority-wide or even a provincial-wide expectation of the kinds of survey questions you're asking patients, but that to be done on a regular basis, and for people to receive comparative reports about where they sit on the bell curve of everyone else's performance, particularly those towards the lower end of the bell curve, would be more inspired to embrace these kinds of opportunities. So that would be top of the list for me. My question is, in the 3 emergency departments that you did this with, was there a bell curve of adoption? Did they all go for their Catalyst grants? Did some do more changes than others? What are you expecting to come as a result of that?
Right. You know what? It was completely fascinating, as I'm sure you can imagine, at the diversity of the sites and how people were able to take things up, what sorts of things resonated, and also how different the departments were, like the volume of patients that they see, the size of the department, the issues that they were trying to address as a department at the time really did seem to influence some of that work. And so, yeah, we're really looking forward to doing that analysis and thinking about how some of those things are taken up. And I think your point to, how do we be a magnet to say, wow, this is actually really great to do and it's rewarding work, and maybe there's a little bit of difficulty at the beginning, as was found in the primary healthcare study, where you might have to surface some tensions and challenge the status quo a little bit. But I think rather than talking about the carrot and stick argument, that we should be talking about the magnet argument, so I see it and I'm drawn to it. So thanks.
Having been an Emerge physician for 20 years, I think we have to realize that Emerge is a very chaotic environment. There's lack of resources. Right now we're practicing hallway medicine. so it's probably not the best environment for this scope. That said, when I was involved with QI, we brought Bevel Up, the movie, to our staff and our resident, and we also brought a Vandu partner. And that had a lot of impact. So I think I would customize that, I would piece it out. The Brian Sinclair case is a good example. The other one that was celebrated at a health talk a couple of years ago, or change agent was about patients with First Nation that had dementia and how they get triggered with security and emerge. So I'd be leery to add to providers that are already overstretched, but you might find a window of opportunity to get the culture and the talk starting, and then maybe create the space for this kind of thing.
Right, thank you, and I really appreciate your perspective, and I definitely agree that, you know, the chaos and actually the distress of providers, and I think sometimes it just is able to speak to that when you can think about how many of the strategies, and I can show you on the toolkit, are actually really simple, straightforward strategies that, you know, you can incorporate. It's just maybe around changing some language or just about making a space a little bit more safe and inviting, that, you know, there can be a whole range of scope, and that is about what the tailoring to context is. And I think your point is also in that how can we integrate equity-oriented healthcare, not make it an add-on, an extra. It shouldn't be something we have to do in addition to. So thank you. Great, someone will bring you a microphone. How is this all funded? It's funded through CIHR. Yeah, so this is a research study, and so we'll definitely be examining, you know, things around sustainability. Each of the partner sites have provided quite a bit of significant in-kind resources as well, and so, you know, we're at a stage in the study now where we'll see how some of the things and some of the activities are able to be sustained over time. But there are, you know, some indications that that is going to be the case in at least one of the sites, so that that people will be able to continue to meet or have these discussions or take further actions. Yeah, thank you.
Thank you, Erin. This is just excellent work. And I do have a quiet worry, I think, as a provider, as a nursing provider and administrator in Northern Health. I think of all the different modules that we have for trauma-informed practice, for cultural safety, for harm reduction, for equity. And I just wonder about the knowledge translation of all these concepts. And again, 3 of them are incorporated in this equity. But how does this make behavior change for providers? And how do people show up with the patients that they serve every day? And so how do we take all these nuggets and translate them into the way we approach the people we work with?
Right. I wish I had like a really clear answer for you. But I think that we have learned that, you know, not to repeat an overused phrase perhaps, but we have learned that education is necessary but not sufficient. And so I think some of it is having those small wins and seeing like what difference it can make, or how when your experience can be improved. And everyone has their different things, right, that's going to resonate with them. For some people it's going to be data, like show me that, you know, sick time's reduced. And other people are going to have other things like, wow, you know, it's the patient experience, or I didn't see that I was lagging, and oh, I'm going to catch up. So I think it really is being attentive to how people change their practice and how people make decisions and what they find salient to them in their everyday work, and it comes from knowing your staff, right? And being able to have those conversations and thinking about those things that is just going to, you know, turn on a little light bulb and maybe make them think about trying something a little bit different, and then having a bit of reward from that.
I'm just curious how frontliner, like first point of contact, so registration clerks or people that are constantly sitting at desks are incorporated. You talked about housekeepers and all of that, but I used to work in registration in an emergency department, and we're the ones that are constantly getting asked the questions because the nurses are running around, or doctors aren't available for obvious reasons. So I'm just wondering if there's any education or things that are provided to people that are usually the ones that are getting the most questions, or supports or resources for those people that are easily at hand.
Right. So in the study, it really varied by site. It was sort of, you know, what the staff had wanted or what our partners at the site sort of had suggested or steered us towards. But I do really take your point in terms of, you know, that there's a lot of uncertainty, and I think that's where, you know, it contributes, right? When people feel uncertain, it you know, can elevate emotions and things like that. And certainly the people who are the first contact, it's really important to think about how they're able to provide equity-oriented health care. So thank you. And I see the moderator lurking, and so thank you again very much.
Thank you for your work and for the presentation, Erin. And now we'll turn it over to Tracey from Saskatchewan Health Quality Council.
Good afternoon, everyone. Thank you so much. So my name is Tracey Sherin, and I'm the CEO of the Saskatchewan Health Quality Council, and we're really happy to be here today to tell you a little bit about a new direction and some new work for our organization. And we're particularly grateful for the ideas stream here at the Quality Forum. We're very early in our journey and still working through some key questions. And so I know there are likely many people in this room who are doing similar work, interested in similar ideas, and have participated as leaders, as community members, as healthcare providers, and we're here hoping that we can learn from you. I have no commercial or financial affiliations to disclose. And for those of you who may not know a lot about my organization, the Health Quality Council is an independent agency committed to bringing about better health and better health care for people in Saskatchewan. Our vision is optimal health and health care for everyone, and our mission is to accelerate improvement in the quality of health and health care throughout Saskatchewan. And we do this primarily through building quality improvement capability, connecting people and ideas, measurement, research, and evaluation, and creating environments that enable collaboration. We are located in Saskatoon, but we serve the entire province of Saskatchewan, which includes traditional territories under Treaties 2, 4, 5, 6, 8, and 10, and is also the homeland of the Métis people. And so I thank you for welcoming me as a guest on these lands today. I also want to acknowledge that I'm here telling our story on behalf of a larger team back home. Very smart, curious, dedicated people who aren't here but are with me in spirit, and also the wise coaches that are helping us. So as I mentioned, we're entering into some new work for our organization, and our vision is to use our expertise as an organization to move beyond the healthcare sector and inspire collaboration and improvement in the broader areas that affect health. So in 5 years, we envision that improved services and collaboration will be happening in communities, and that will address the social determinants of health to enable children, youth, and their families to lead healthy lives. So we want to focus our work on children, youth, and their families who are experiencing or who are at risk of experiencing mental health or addictions concerns, given the strong link we know between social needs and mental health. We know we're not alone in this vision and that many others are doing similar work, perhaps people in this room, other people in Saskatchewan and across Canada. And we're hoping that the dialogue here today can help us all learn from each other. And I do want to acknowledge a former colleague of ours, and we've learned a lot from, who worked on the BC Child and Youth Mental Health and Substance Use Collaborative, and I'm sure there's other work here that we can learn from as well. So our organization has previously done measurement and analysis work related to mental health, looking at primary care, patient experience, and predictors of high-cost health service use. We've also conducted several learning collaboratives, with one in particular focused on depression. Much of our previous work was focused right within the healthcare sector, and so the new piece for us is that we are expanding our focus beyond healthcare. So to understand a bit about how we arrived at this situation as the Health Quality Council, might be helpful to understand a bit about the context in our province now and in the recent past. So in 2017, the Saskatchewan Health Authority was created, which amalgamated 12 of our 13 regional health authorities into one. So this change caused many other organizations within the health sector, including ourselves, to re-examine their roles to align with this new structure. And for us, in the past, we had played a role as an integrator between various organizations and regions in our province. As the health authority came together and matured, there was less need for that, in particular across those geographic regions, and in particular within the health sector. So this gave us an opportunity to understand how we as an organization could play a role to integrate across sectors to enable collaboration to improve health. At the same time, improving team-based care in the community emerged as a high priority in our health system as the health authority worked to establish local health networks. And as we know, truly team-based care means collaboration outside of the healthcare sector with other agencies and services that provide service to people in the community. Improving access to mental health and addiction services was also a system priority. And many of us recognize the importance of connections and integration with other services to support health outcomes. And we were really starting to see a desire among many organizations to collaborate, but they struggled with how to make that happen. Collaboration is work, it doesn't just appear out of nowhere. So recognizing these opportunities, and along with our board, as part of our strategic planning and process in 2019, we started to think about how we could use our skills and expertise to address the broader determinants of health. So given this direction, we set out to identify what, as an organization, we could do. So we held meetings with community groups and organizations to introduce ourselves, find out about the work that they were doing. We got a lot of ideas about what they were trying to do and what might help them get there. And we also saw this as an opportunity for them to get to know us a little bit because we had never interacted with many of these organizations before. We conducted a comprehensive environmental scan that included extensive review of social data sources in Saskatchewan, literature, government plans and strategies, and stakeholder maps. And we've also had the opportunity to meet twice with senior leaders in our ministries of health, education, justice, and corrections and policing, to name a few, to explore how we might work together on shared goals. We've also discussed a framework that highlights the various levels of the system at which we can act and looked at the influence between those different levels and different actions we can take, and I'll get back to that in a minute. We've also been very lucky to have some great coaching support from experts both within Canada and across North America. This left us with a lot of ideas and options for action, and we quickly recognized that with a small team and a lot to learn, we'd have to create some focus for our efforts. So that's how we arrived at our vision. And why children and youth, why mental health? This aligned well with work already being done in our health system, so it wasn't a stretch to start thinking about moving from the work that was already being done to collaborating with potentially other organizations that could help serve those communities. And we know that there's a strong link between the conditions of everyday life for children and mental health outcomes later in life, as described by the World Health Organization in their report on the social determinants of mental health. And because we needed to start somewhere. So I mentioned on the previous slide, we had a lot of ideas about things we could do. We felt the absolute worst thing we could do was nothing, because we were afraid of taking the wrong first step. So we decided to take a first step and then learn from there. The other piece was thinking about what a small organization like ours, we're less than 50 people. We don't provide direct care services. So really, what can we do to help people do the hard work of improvement and collaboration? So we can build quality improvement capability across sectors. We can create cross-sectoral learning networks and learning communities and collaboration models. We can use evidence to inform what works, why, and for whom. And we can develop and strengthen relationships through service-based learning. So those are some ideas about how we can affect change. We've also done some thinking about how we'll measure our success. So we'd expect that, in our first year of our 5-year vision, we need to learn, we need to build relationships and build readiness for change. Further down the line, we'd like to see that we've built or completed at least one learning collaborative, learning network, or learning community where teams have been able to make improvements in process measures, build new relationships, and improve experiences for their clients. And further down the line, we'd like to see we have more experience in building collaborations under our belts, that teams that are involved are making improvements to processes and outcomes, and that we're able to take what we've learned to scale up our improvements to new topics or subject areas. So that's our journey so far. And as I mentioned, we're still grappling with some questions about how to move forward. I'll share a couple of those with you now, just to prime the discussion. So I mentioned we did have started thinking about the different levels of the system at which we can act. The question for us is, with a small team and not a lot of resources, where do we start? Do we start at kind of the more micro grassroots level? Do we start with the system leaders, all of those all at once? What level of engagement do we need at each level? Where is it most critical to start? Our gut tells us it's with community and it's with grassroots, but we struggle with what to do at other levels and how to sequence that. And we really also just want to learn from others who've gone down this path. So if you've done similar work, what were some of the key success factors for you, and what would you do differently if you had the chance? So with that, I'll thank you for listening to our story. I'm happy at this point to take any comments, questions, or words of wisdom that you might have for us. Thank you.
My simple listening to what you just said was you want to connect the health system with community social services.
Yes.
That part of it. Okay, so
Yes.
Is there any evidence in other jurisdictions in the Western world where this has been done to great effect? And
Yeah, and so I mentioned we've learned a lot from colleagues who worked on the BC Child and Youth Mental Health and Substance Use Collaborative. And I think one of the great things that they did was build local action teams with community leaders and representatives, youth representatives, and individuals from, based on the community and what they needed, policing, social services, healthcare, the mental health services, and brought them together on teams to figure out what changes they wanted to try. And that did lead to a lot of success in many communities. And so that's a model we're modeling ourselves after, and there are others across North America as well. Yes.
Well, I thought it was a really interesting presentation, and you asked for feedback. So,
yes, please.
I'm not involved in this issue specifically. In other issues, I believe we should think macro, act micro. Because that's where it really hits the road, and that's where the most work has to go in developmentally.
Yeah.
But you still have to keep an idea on the macro, because that's where all the funding comes from.
Absolutely.
But the hard work, you can come up with the ideas really fast, but to actually implement them and actualize them is really where, very vital and important.
Yeah, and that's one of the things we think about. If we start small, how do we set the conditions to be able to spread what we learn to larger and larger groups and communities and areas? And I think the advice you've provided will help with that, is to set the stage then for setting the conditions where that can happen. Yeah, thank you.
I'm Robin Routledge, and the presentation is daunting to me because it's like the whole province, right? Mm-hmm. And I think one of the principles is that important change is local. Yeah. So I would want to see you focusing on local, like community level change. So, and there are quite a few of examples of that around the world, but I'll just tell you that in Cowichan, there was a disaster for the health authority where they lost the confidence of the entire community a few years ago, and big petition, outrage, and it was a inspired catastrophe because Island Health responded to it very positively by saying, we would like to engage the community in having a voice in planning healthcare and wellness for your community. So an organization called Our Cowichan Community Health Network grew out of that, and now it spreads. I think there's 50 little organizations, health authorities involved, some medical staff are involved, the school system, all of local government is involved. So they discuss health questions that are in the community and what to do about it. We discovered that Cowichan had the highest rate of child pulmonary disease in BC. So they did air quality surveys that were triggered by this community organization and found out that we have the highest air pollution, and it's from backyard burning. Mm-hmm. So all of the municipal governments passed bylaws saying you can only burn on these occasions. So now we only have poor air quality during those weeks when burning is allowed. So I mentioned that to you as an example of how a health authority was able to encourage a community to develop a local voice and participation.
That's a great example. Thank you. And I think that's exactly the kind of collaboration and partnership we want to inspire. So thank you very much. Okay. There's one more.
I just want to, so I'm working on another quality improvement project within BC Cancer, and one of the things that I'm seeing that would really support the comments have been think globally, act locally, but not to forget that meso level, because your local things are never completely isolated. They're part of communities, they're part of larger networks, and you want to make sure that those larger networks knows what's going on and how they can be engaged or maybe need to be engaged, because your individual is never going to be isolated just within a single clinic or a single environment. They're connecting within the community. They may be connected larger. And so you need that awareness even when you're acting locally, or things will fall flat.
So it sounds too like there's a smaller local group that you're working quite intensely with to support change, but there might be a larger, broader community to kind of keep informed, keep in the loop. And that may require less intensive support, but shouldn't be forgotten. Yeah. Which helps when you have a small team to know where to focus your efforts. Yeah. Thank you. All right. Thank you very much.
Thank you to all of our presenters. Thank you for being here. If you guys could take just a few seconds to fill out those yellow evaluation forms and leave them on your chair. Thank you very much.